the imaging diagnosis of a prostatic and metastatic prostate cancer, PSMA PET scan. Speaker, Dr. Kornejeva, radiologist from North Estonia Medical Center. Please, lecturer.
Good morning, dear colleagues. My name is Alina Kornejeva. I'm a radiologist from Nuclear Medicine Department from North Estonia Medical Center. And it's my pleasure to give a talk about PSMA PET CT based on our institution experience. So first of all, where I'm from North Estonia Medical Center, which is one of two higher level hospitals in Estonia, and it provides medical services in almost all specialties, except of pediatrics and obstetrics. And since 2002, we have a nuclear medicine department, and we provide both diagnostics and treatment. For diagnostics, our everyday study is FDG, and we have EARL accreditation. Once per week, we perform PSMA with F18 labeled PSMA, and we also sometimes perform flutometamol or Visamil for Alzheimer's disease. And PET choline we are now using exclusively for complex cases of parathyroid adenomas. And from conventional nuclear medicine, we provide all classical scannings, bone scan as well. And for neuroendocrine tumors, we still perform technetium-labeled tetrotyte. And for treatment options, we have treatment with radioiodine, a radium treatment for bone metastasis in prostate cancer. And we also perform a 177 lutetium dotatate treatment for neuroendocrine tumors and 177 lutetium PSMA treatment for prostate cancer. So I would like to give a very short review of the topic and make this presentation more case-based. So PSMA, we already saw yesterday and today that it's prostate-specific membrane antigen, but actually it has quite many different names. We know it as PSMA in oncology. And this is a glycoprotein which is found to be overexpressed in vast majority of prostate cancer cells. Primarily neuroendocrine tumors of prostate are less likely to express it. And what is important that its expression levels increases even further according to stage and tumor grade, and found to be upregulated when castrate-resistant phenotype evolves. So this is clinically relevant prostate cancer have a chance to upregulate PSMA even more. And PSMA-based PET is not just one scan study, as we saw. This is a group of studies, and they share the same idea, but they have slight differences. Two isotopes to label PSMA that are in use currently, and 68 gallium as and 18 fluorine. And as I mentioned, the prostate-specific membrane antigen is actually a little bit misleading name because it's not that specific exclusively to prostate. First of all, we have a physiological uptake, and that might depend on tracer we use. But almost always there is an uptake in salivary glands, lacrimal glands, in liver, duodenum, spleen, ganglia, and in kidneys. But if we have F18 labeled PSMA, those tracers usually have primarily hepatobiliary excretion, and due to that, we have a higher uptake in liver, but a quite low uptake in bladder. This is an example from literature. The first scanning of the same patient is F18 labeled PSMA, and another one is 68 gallium. And as you can see, with gallium, we have a higher uptake in bladder, but again, it can be somehow managed with patient hydration, but still F18 might get a better picture for local staging, but usually it's not an issue because we have an MRI for local staging. When it can be important if we are searching for small local recurrences. When we use PSMA PET-CT, these indications are in our institution. We use it for all primary staging in high risk and intermediate risk prostate cancers. Gleason score starting 4+3 and PSA as shown. We use it for biochemically recurrent disease starting from 0.2 of PSA level. And it's also important to mention that this scan should be done if it actually has a potential to change patient management. If we once performed PSMA PET scan, it's logical to follow up and assess treatment response with it as well. And we do it prior isotope treatment. Always when we want to perform lutetium PSMA treatment to show an expression of PSMA. And in some cases, when we want to perform radium treatment, we also use PSMA PET scan. We always have to be sure that there are no visceral metastases. And PSMA PET scan may sometimes be the best option for that. And in Estonia, I have to mention that PSMA PET-CT is now reimbursed, so we are quite free to use it in our patients. Procedure itself is quite simple. Patient don't need to fast or any other preparations. We inject 2 megabecquerels per kilo, and after that, patient has to wait 2 hours for distribution of this radiopharmaceutical. And after that, patient goes to our scanner, and we perform diagnostic, usually contrast-enhanced CT in portovenal fats. And for this stage, most of our patients have priorly MRI, but we still start description of our study with local staging, including multifocal, unifocal lesions, seminal vesicle involvement. Then we move to description of lymph nodes, and as shown on this scheme, we are now trying to standardize our reports within Estonia. We have 3 centers that perform PSMA PET scans. So in order to make our clinicians' life also more comfortable, we try to name things quite the same and structure them the same. So this is an example of a 66-year-old male. He had surgery, and he is known T3B Gleason 8 tumor. His PSA level after surgery is still 0.39. So he was referred to PSMA scan for staging and to search where is the disease. So you can see on his right parailiac region lymph node, which is 6 to 7 millimeters. It could be suspicious on CT, but based on CT only, we can't tell for sure if it's metastasis or not. And if we have a look on PSMA fusion scan, it shows really high uptake of PSMA, so no doubts that this lesion is metastatic lymph node. And this is an example of a 53-year-old male. He has a T3 adenocarcinoma, Gleason 4+4, and PSA 58. You can see in his prostate, dominantly in right lobe, intensive uptake of PSMA. And there is also a small focal lesion in his right seminal vesicle. And the only bone metastasis that could be found is in his right inferior ramus, which shows high uptake of PSMA and also show a typical sclerotic change in bone structure. So this is a definite bone metastasis. As I mentioned previously, prostate specific is actually not that specific, and there are quite several pitfalls. Well, one of the most common is uptake in ganglia, and those ganglia could be found in neck, thoracal, lumbar, and also pelvic region. So sometimes it could be a problem to discriminate them from lymph nodes, but usually it's not a big problem. Ganglia are linear structures, usually symmetrical, And if you know that they exist, you always have to think about them. Benign bone diseases such as healing fractures, degenerative bone changes, fibrous dysplasia, Paget's disease, and hemangiomas might also show quite high PSMA uptake. Other malignancies such as renal cell carcinoma, hepatocellular carcinoma, breast, lung, salivary glands, and many others actually can also express PSMA, and PSMA can be expressed on tumor surface themselves or in pathological endothelium. Benign neurogenic tumors show PSMA uptake. Granulomatous inflammations, sarcoidosis might show uptake, and androgen activity also might affect the PSMA uptake. This is a 71-year-old male, and he has T2C Gleason 8 tumor. He's PSA 9, and he was referred for primary staging. So he has multifocal PSMA of a tumor in his prostate, as you can see on MIP image, and in both axillary and in hilary and mediastinal region, he has non-specific lymph nodes which show faint uptake of PSMA, and in this clinical scenario, they're not likely to be metastases. Those are non-specific reactive lesions. And this is a 67-year-old male, Gleason 4 plus 3, PSA 7, primary staging. According to his MRI and biopsy, he has a small focal lesion in his right lobe of prostate, a tiny dot with red. And on PSMA scan, we found a bone lesion in left pelvic bone. But if you have a closer look on CT image, this bone lesion shows more benign appearance. So nevertheless, it shows a high uptake of PSMA based on CT. This was described as a benign lesion. And no definite bone metastases were found in this patient. And you can also mention that in his spleen, there is a very intensive focal uptake, which corresponds to unvividly enhancing lesion in spleen. Based on CT, it was suspicious for hemangioma. Patient was referred to MRI, which also confirmed that contrast enhancement is typical for hemangioma. And this is a 55-year-old male, Gleason 4 plus 3, PSA 8.8, and referred for primary staging. As you can see in his left lobe of prostate, there is intensive uptake of PSMA, his tumor. No lymph nodes were found. And in his right rib, you can see a faint but quite focal uptake of PSMA. No underlying changes are seen on CT. This is, fortunately for us, quite faint uptake. So after all, we decided that this is a non-specific lesion. And ribs are actually one of the most common sites of those non-specific uptakes. And those non-specific bone lesions are really a headache for radiologists, not only for us, but from all over the world, because they exist. And the European Association of Nuclear Medicine has published a standardized reporting guidelines, which we're trying to implement. We don't use actually this 5-point score, but we try to describe those lesions accordingly. So based on that, definite prostate cancer metastasis could be reported if you see both intensive uptake on a site typical for prostate cancer and definite finding on CT. And it is separately mentioned that definite finding means presence of real anatomical substrate. So this is a definite metastasis, but if you already can see it on CT, then why you need PSMA? So probable prostate cancer metastasis is when you see intensive uptake, but no definite finding on CT, or no finding which is typical for benign lesion. So when we report the probable prostate cancer metastasis, it is very likely that it might be actual metastasis, but there is always a small percentage that it probably might not be. And if we talk about F18 labeled PSMA, things get even harder because we always get a quality control for our radiopharmaceutical. But in theory, some F18 might unbind from PSMA, and we got free F18, which also can show some uptake in bones. This is a 74-year-old male, T2C tumor, Gleason 4+3, and he has a biochemical recurrent disease, PSA 0.26. And on his right parailiac region, there is a PSMA avid lymph node, which is likely to be the source of his recurrence. But you can also see that in his right kidney, he has a hyperdense or enhancing lesion. We have only one phase. And this lesion shows intensive PSMA uptake. So he had a surgery and he had a confirmed renal cell carcinoma. This is 71-year-old male, Gleason 4+3, and he also has a biochemical recurrency, PSA 0.84. And you can see quite multiple PSMA avid lesions. Some of them are in right parailiac lymph nodes, some PSMA avid bone lesions, but he also have pancreatic lesion and lung lesion. So this is not really clinically likely to be metastasis of prostate cancer. And you can also mention that his left kidney is missing. So it turned out that 13 years ago, he had a renal cell carcinoma, which was operated. And based on this, it's more likely that he had a recurrency of his kidney cancer. It is really hard to tell about lymph nodes and bone metastasis, which of the tumors gave those, but his kidney cancer might be more clinically relevant at this stage. This is 53-year-old male, Gleason 4+5, PSA 18. He was referred to primary staging. And in his prostate, you can see a multifocal PSMA avid tumor, no pelvic or other lymph nodes, no bone lesions. But you can see in his left lung hilum and in his left atrium intensive PSMA uptake, quite a huge tumor, which also prolapses to his left ventricle. It is more likely to be the lung cancer, but unfortunately, after 2 weeks, patient died, and we don't have a histology. This is 81-year-old male. He has known non-small cell lung carcinoma, and because of that, he had a staging with FDG PET-CT, but he also has known prostate cancer, Gleason 4+3, and PSA 18. So on his first FDG, we can see FDG uptake in his right lung apex tumor. There is a pathological metabolically active lymph node in right hilum. There is a focal uptake in his right salivary gland, which is more likely to be pleomorphic adenoma or Bartani tumor. So this patient is very likely to be smoker. But you can also see some spots here, and those are corresponding to sclerotic bone lesions. But on CT, we could see much more sclerotic lesions, which didn't show FDG uptake. So the question is, which tumor gave those bone metastases, lung or prostate? So he was referred to PSMA PET scan, and here you already can see much more PSMA avid lesions, and those sclerotic lesions in bones which were not FDG avid show a high uptake of PSMA, so those are likely to be prostate cancer metastasis. And you can also mention that his lung cancer is not expressing PSMA, but I can tell that between those two scans, patient already started external radiation, so this could be due to response. This is 77-year-old male. He has metastatic castration-resistant prostate cancer, T3A and 1 and multiple bone metastasis. His PSA is 73, and he was a candidate for radium treatment for his bone metastasis. Prior radium treatment, we performed bone scans for all patients, So you can see one of the biggest lesion in his vertebra, but you can also see that his bladder is very full. And I'm completely sure that our technicians always ask patients to empty their bladders before scanning. So this is very likely that he has actual urinary retention. And based on SPECT CT, I can see that his prostate is enlarged, but I can't tell anything more about it. So we performed PSMA scan, and you also can see that his bladder is still full, and you can see his prostate, which is enlarged, and it diffusely full of PSMA heavy tumor, shines like a red giant and already causes local symptoms like urinary retention. It also infiltrates seminal vesicles. So his prostate is the main tumor burden, and radium treatment for 6 months for this patient is not the best option because it targets only bone lesions. For now, we can't combine it with other therapies, and PSA follow-up won't be informative in this patient. A few words about diagnostics. We already heard about it yesterday also. If we change diagnostic isotope for treatment isotope 177 lutetium, then we have a pharmaceutical which we can use for therapy. And the European Association of Nuclear Medicine published a guideline for this procedure already in 2019, but we were very waiting for VISION trial results. VISION trial is a phase 3 open label international quite big trial which explored lutetium PSMA treatment in metastatic castrate-resistant prostate cancer in patient group who received almost all possible treatments priorly and progressed, and it compared lutetium PSMA with best standard care, and it showed both progression-free and overall survival prolonging. So it's life-prolonging treatment, and it's really great to have this option. We need more trials, but this vision is already very promising. And I personally wait for the results of trials which explore enzalutamide in combination with lutetium PSMA, because those two might even have synergistic effect and raise efficacy. And last year we had an opportunity to start with lutetium PSMA treatment. This is one of our patients, 74-year-old male, and he priorly had chemo, abiraterone. He didn't receive radium treatment because he had multiple bone lesions, but he also has enlarged lymph nodes, which are bigger than criteria allows for radium treatment. Lutetium treatment is now not reimbursed in Estonia, so he referred to a foundation which helped him to get this treatment. And the first picture is his PSMA scan before we started. So he shows a really high uptake in all pathological lesions. He has a huge lesion in his left hip, which was already previously irradiated, but it still hurts and progresses, and multiple lesions in bones and lymph nodes. Another picture is his scanning on lutetium PSMA activity, the first one. So it's basically more or less the same, but a little bit more blurry picture. And we always perform a restaging after 4 cycles. If we still have residual disease, but we have a partial response and see no complications, then we continue with 2 more cycles. So we did in this patient. And his last picture after 6 injection of 7.4 gigabecquerel of lutetium PSMA. We can see radio tracer in his bladder, but you can see that his left hip and other metastases show much lesser uptake of PSMA, and most of them are now gone. But yes, there is always a possibility that they just don't express PSMA. But based on his PSA, he has an actual response, dropping from 358 to 14. So we're quite lucky about that. Of course, this is one of the best cases because we always show the best cases. So take-home messages. PSMA overexpression is present in vast majority of prostate cancer cells and even more in clinically relevant disease. So PSMA-based PET is not just one scan, it's a group of scanning, and you have to be aware of slight differences that might be between scans. It is also very important if you want to follow a patient, it is better to do it within one center with one machine. This study exam could really change patient management in some cases. It has shown to be accurate, to be sensitive in N and M staging, but by gaining a high sensitivity, we sometimes sacrifice a little bit of specificity. So we have to be aware of benign and malignant pitfalls. Those bone lesions, non-specific bone lesions are existent, and we have to be very careful with them. We have to describe them and take into account all patient's history, patient risks. And patient's history is really crucial, so referral letter is very important. We need to know PSA, we need to know Gleason, and we also need to know, do patient have any other conditions? And last but not least, isotope treatment options are coming. I really hope they will become more available in the near future, but it definitely will take some time. So looking forward to that. And with that, I would like to thank you for your attention. And if you have some questions, I will be happy to answer them.
Questions, please, auditory. I ask in the auditory would not be shy and ask a question in written form during presentation, please, if it's possible. So I would ask you personally, how long you have possibility in Estonia provide PSMA PET scanning for patients?
We started from 2018. Firstly, though, those were much less scans. Urologists were also quite skeptic, but now we have them weekly, 6 scans on Wednesdays. And yes, it's become popular.
Thank you to you for nice presentation, and nice to hear that about improving possibility for imaging of metastatic
Thank you very much.
cancer.
It was a very pleasure to
See you. Bye.